Center for Optimal Aging. I would like to welcome everyone to our virtual colloquium. And the speaker for today is Dr. Donna Levanti Rafael. She is a gerontologist and the director of the National Memory Screening Program at the Alzheimer's Foundation of America. Welcome, Donna. Donna is going to present her research on the topic of the stigma of Alzheimer's disease and the barriers to early detection and screening. She's also going to be talking about the role that providers and primary care physicians can play in removing these barriers. Donna is very passionate about her efforts to bring about social change and facilitate positive health outcomes among older adults experiencing cognitive impairment. So welcome, Donna. Before I turn it to you, a few logistics. We are going to be taking questions at the end of Donna's discussion, and you will need to type in your question in the Q&A box of the webinar, and then we will monitor it and we will take questions at the end of her lecture. So
thank you so very much for that wonderful introduction. Good afternoon, everyone, and welcome. Today is a great day. I'm here going to be giving this presentation, so I hope that you have the opportunity to learn. I always let my guests know that if you see that there's information that you would like and need, you can feel free to take pictures of the slides if you need them. Okay, the topic of this presentation is the challenges of the stigma of Alzheimer's disease and how it delays the early detection and diagnosis of Alzheimer's disease. Okay, somehow I am a little stuck here.
Uma, you might need to be in control.
Actually, she just has to do the request, answer the request.
there you go.
There you go. Okay, I'm still not getting there. Okay, so you're going to have to do the control. So next slide, please.
1 second. Okay.
Perfect. So the overview, we've got a few topics that are, put together in this presentation. The first is normal aging versus dementia, Alzheimer's disease, barriers to early detection and diagnosis, the stigmas of Alzheimer's disease, the importance of early detection and diagnosis of Alzheimer's disease, and the recommendations, which would be addressing the perceived negative attitudes and perceptions of both Alzheimer's disease and diagnosis. Next slide, please. So I'm going to give you a little background here on, what this whole situation is about. So Alzheimer's disease is a significant issue. It's a significant health concern, and it's a growing public health issue here in the United States, for which I certainly believe, I'm one of the many who actually believe that early detection and diagnosis is very, very crucial. It affects more women than men, and you're probably sitting out there, if you're a woman, you're trying to figure out why. It's usually because women tend to age, we tend to live a little bit longer, so we get to age more than men, and therefore the disease actually, helps us along, but it's there when we get older, some form of that disease, of dementia. Here in America, our healthcare is going to absolutely be challenged. Why? Because the size of the older adult, starting from the baby boomers who will probably age out in about by 2030, there's going to be much, much more of us out there. And also the training. Physicians, I will call them primary healthcare physicians, the healthcare, situation, they're not being trained. So those are the two things that we're going to be challenged about, training and size. Currently, Alzheimer's disease is actually based upon the suspicion of the individual with the changing cognitive issues and their caregiver or their caregiver. So whether it be husband, wife, a spouse, or if it is an adult child, usually they would see those changes. The stigma of Alzheimer's disease also creates a barrier when it comes to help-seeking behavior. And when I say help-seeking behavior, I mean medical help-seeking behavior. Next slide, please. So we're going to talk about Alzheimer's disease. You can go to the next slide. So before we go into Alzheimer's disease, we're going to talk about what normal aging is versus dementia. So normal aging is when the changes are minor. Yes, you are getting older, but they are minor. They're not controllable, but you can work with them. These changes actually result in the natural slowing process and or the decrease in the efficiency within our bodies. So in normal aging, your brain and your body actually begin to slow down. They say that your intelligence level does not change, which is actually a good thing, but it probably works a little bit slower for you to be able to retrieve that information. In terms of experience, you're going to experience some changes when it comes to your memory, and that always ends up manifesting some sort of trouble when it comes to recalling the new information. And I would say new information, for example, would be, I just watched this television show. What was the name of it? Oh, I have no idea. I don't remember. It's like that, but then when it comes to normal aging, you can recall the information, perhaps a few minutes later, a day later, but you'll recall the information. Now, in terms of dementia, and I just want to put a side note there, in this particular presentation, dementia will be used, Alzheimer's disease will be used, and the abbreviation AD will be used. They all basically are going to be meaning the same thing. Okay, so whenever I need to clarify, I will. So dementia is not a normal part of aging. It is a progressive disease that also causes cognitive functioning to break down abnormally. It causes cognitive and your physical symptoms to actually worsen over time. As I mentioned, it's progressive. It will only go forward and not backwards. When it comes to dementia, these changes happen frequently and they become disruptive symptoms. And at this moment, there is no cure. Next slide, please. So what I've done is put together some examples of what normal aging is like and then what dementia is like. And these are just considered the early stages. So when you hit the age of, say, 65, 70, you may experience issues of recalling the name of your friends, places that you've gone to, and it's not because you've forgotten. It's a little slower. You're having a little slower time remembering. You might forget about some of your appointments or your events, and then you recall. You'll take a little longer to process your information. There's going to be times when you're going to lose track of where you are in a conversation, and occasionally you're going to actually forget where you've placed an item. And that does not mean you have dementia. It simply means that your brain is slowing down and you absolutely will recall it. And I will tell you, being the busy person I am, when I used to drive, I would take the keys, rush in, play with the dog, talk to the child, thinking of dinner, and I put the car keys in the refrigerator or in the freezer. But I always recall because I need something in the freezer. So I'm like, oh, this is where my keys are. Oops. And you recall where you've put these keys. Now, in terms of dementia, there's a difference. You're not remembering the names of your family members or your friends or other relatives. You're forgetting your appointments and your events completely. You're having trouble verbalizing your thoughts. You're tending to pause when it comes to having conversations. And you're absolutely substituting common words. And when I say common words, it could be a word like day, book, TV, and you're finding other words to make sense of what you're trying to say. You're regularly repeating your statements, you're repeating your questions to the same person over and over. You're consistently misplacing your items. You're getting lost in familiar places. So for example, if you're used to driving and you're getting on a highway and you know that you take exit B6 or B7 to go play golf, and you've been doing this for the past 20 years, all of a sudden, you're not sure of which exit you're going to get off of, so you continue to drive. You also have changes in your mood and have the inability to focus. The difference between normal aging and dementia is that you're able to recall this information when it comes to normal aging. When it comes to dementia, the likelihood tends to increase that you're not going to be able to recall that information. Next slide, please. So Alzheimer's disease. What is Alzheimer's disease? Alzheimer's disease is a chronic neurodegenerative progressive disease. It starts off very lightly, very slowly, and you'll see the gradual differences within that person over time. It's usually common within people who are ages 65 and older. However, we have been finding that people between the ages of 20 and 55 are starting to get more Alzheimer's disease. They call it early onset. And we're not quite sure why this is actually happening, because you can no longer say for them that age is what the highest risk factor. So that is still a conversation that is being had with researchers. Alzheimer's disease is the most common of the dementias. There are quite a few dementias out there, but when it comes to Alzheimer's disease, that is the one that when you go to the doctor, or you are going to see Alzheimer's disease being diagnosed even more so than any of the others. Now, remember I said earlier that I'm going to use dementia, AD, and Alzheimer's disease. So let me explain to you dementia. Dementia is considered the umbrella term that is used to describe progressive diseases when it comes that actually affects your memory, your thinking, your behaviors, and your ability to actually perform activities of daily living. And what are activities of daily living? Those are, the things that you do regularly. So if you sweep your house on a regular basis, you make your bed, you take a shower, you brush your teeth, you cook dinner. Those are activities of daily living. Dementia always affects those. Now, I put a little sidebar at the bottom where it will actually say Alzheimer's disease is universally feared and stigmatized because it is often mistaken as and viewed as a normal part of aging. And as I said before, Alzheimer's disease is not a normal part of aging in any form. Next slide, please. So what is the scope of this epidemic called Alzheimer's disease here in the United States? Well, Alzheimer's disease has now crept up to being the 5th leading cause of death for those people ages 65 and over. I believe it had changed probably about a year or 2 years ago because of COVID. It's now shifted places again. So it's now at the 5th leading cause of death. It is categorized as a public health crisis because so many people are, getting this disease, and the populations are actually growing. So you're going to see more people over the age of 65 than before. It's never happened before, but it's happening now. The CDC, and according to CDC, there's an estimated 6.5 million people with Alzheimer's disease. And I believe those are the only ones who've been diagnosed with Alzheimer's disease. So when we think of this number of 6.5 million, we have to think of all those people who have not been diagnosed, who have not gone to a doctor, who have not self-reported that they may have the symptoms of Alzheimer's disease. So that number really is a whole lot bigger. In 2060, the CDC has also estimated there's going to be approximately 13.8 million people with Alzheimer's disease right here in the United States. Of those 13.8 million people, 60 to 80% of these individuals will actually have Alzheimer's disease. Others may have a different form of dementia, such as, frontotemporal or Parkinson's disease, but 60 to 80% of people who actually get diagnosed, it's usually Alzheimer's disease. As I mentioned, it is the most prevalent of the diseases when it comes to dementia. Did you know that there were over 11 million actual caregivers, family caregivers who are actually taking care of these loved ones? That is a lot. It's a lot of family caregivers, and these individuals are totally unpaid caregivers. So when we think of this epidemic, we don't just think of those people who have Alzheimer's disease, we also have to think of those who are their caregivers. Next slide, please. Alzheimer's disease has non-modifiable risk and they have modifiable risk. On this slide, the non-modifiable risk factors are, there's 4 of them. Age, which you can't do anything about. Family history, you may be able to do something about, but not really. Your education and gender. So with age is the number 1 risk factor for Alzheimer's disease. As I mentioned, 65 and older. So after the age of 65, Alzheimer's disease, the risk factor actually doubles every 5 years. When it comes to your family history, it's the genetics and your environmental factors. In terms of education, if you have fewer years of formal education, or you have lower levels of cognitive engagement, that could be also a problem. And also you cannot do very much. You can do something with your formal years of education. You can go back to school, or you can learn new things. In terms of lower levels of cognitive engagement, you can actually increase that. You can make a conscious decision to increase your engagement. In terms of gender, 2/3 of people who are affected by Alzheimer's disease are women. Remember, I did say that women tend to be the largest number of people who have Alzheimer's disease. 16% of these women over the age of 71 and 11% of the men who are over the age of 71 get Alzheimer's disease. Women who are over the age of 65, they are 1 in 5% chance, while men are 1 in 11% chance of getting Alzheimer's disease. Next slide, please. Modifiable risk factors. So in modifiable risk factors, these are where you can actually contribute to doing something about you either preventing Alzheimer's disease or slowing, the process of Alzheimer's disease. They say that up to 40% of dementia cases could be prevented if you just address your lifestyle factors. So lifestyle situations would be, what you eat, your physical activity, your social connections, as I mentioned, social engagement, and your education. Those 4 things mean a lot. Those 4 things can actually make changes in your life that you can prevent Alzheimer's disease. You can slow it down greatly. What they ask us to do is to decrease certain things. And these decreases actually can lead to Alzheimer's disease. Now, there's no 100% proof or conversation about the decrease, but when you break these factors down, they actually make sense. Some of these would be diabetes, high blood pressure, cholesterol, high cholesterol, air pollution, excessive alcohol intake, obesity, smoking, hypertension, depression, even head injuries, whether you are very young at the time or even now. If you fall and you have a head injury, it can actually exacerbate the situation and you can have an onset of Alzheimer's disease. Next slide, please. Barriers to early detection and diagnosis. You can go to the next slide. Perfect. Okay. So brain health equity. So when we think of population aging, we find that it can lead to the dramatic increase in Alzheimer's disease and other related dementias. Why? Because, as I mentioned earlier, the population is going to get older. The population is going to be so great. Why? Because we've never had it before. There's more people who are living a whole lot longer. So there's that dramatic increase that's going to be happening. When it comes to dementia, it's going to be a costly situation. Costly because the disease is costly. The estimated annual expenditure right now is over $200 billion. And that is for situations where the person has to go to the physician, the person has to go to the hospital, they have unnecessary surgeries, all because of Alzheimer's disease. There's going to be also differences in the rate of dementia when it comes to the diverse populations. And I did not put populations there, but diverse populations. So when it comes to diverse populations, each group is going to have a different prevalence of Alzheimer's disease. For example, African Americans at this moment, they're stating that they're going to be having the highest prevalence of Alzheimer's disease because of certain situations that include their health and socioeconomic disparities that they experience. When it comes to other groups, there are other situations. The same also goes for the Latinos, and we also call them Hispanic population. So health and socioeconomic disparities are often stronger determinants than race or cultural identifiers of the difference when it comes to dementia prevalence. So when you take those groups, you have to also think of all those other situations that they're going through. It's not just health. In this page, we speak about while leading the risk factors for dementia, it includes the age, and as I mentioned, the genetic risk factors. Some of these are modifiable. A reasonable proportion of risks are attributable to the conditions that can actually be changed. So you have the opportunity to make changes in your own lifespan to, as I mentioned, to prepare to not get Alzheimer's, or at least try to prevent it. That leads you to having a better quality of life. Now, dementia prevention actually depends on what actions you take, because you have to be conscious about your brain health and how you're going to take care of your brain health. Whenever I give a presentation, my biggest thing is, what are you doing for your brain health, right? It's not just about Alzheimer's disease, but it's about taking care of your brain health from when you're very young right through until you age out. So the first thing you want to do is make sure you get quality education. Now, it doesn't have to be an Ivy League education. It doesn't have to be a university degree. You just have to be learning. Learning can come in many formats, as I mentioned before. It can be dance. It can be learning to play the piano, even if you're no good at it. Your brain is working. A healthy diet. So reduce the meat, reduce the fried foods, reduce the junk foods. Make it a little bit more holistic, make it a little bit more wholesome. The treatment of the condition, such as diabetes, make sure that if you have diabetes, you've been diagnosed, whether you have hypertension, high cholesterol, you're smoking, make sure that you're not only monitoring it, but you're actually managing it. And the way to manage it is to actually go to your physician to ensure that you get whatever therapies you need, whether it be drug therapy or non-drug therapy. Those risk factors actually can minimize you getting dementia. Therefore, your health and socioeconomic disparities, we already know that they are contributors to brain health. So that's something that you have to change and promote your brain health. Next slide, please. So we talk about barriers to diagnosis of the treatment of Alzheimer's disease. There are quite a few barriers, and I think some of them I left off, but these are the probably most important. And I mentioned stigma first because that's what we're going to be speaking about. So stigma can be in several formats. It could be self-stigma, family stigma, society, and your healthcare professional. Then we also have the misconceptions of Alzheimer's disease, and that can be both society, self, and also with the healthcare professional. There's a negative experiences that people have with healthcare professionals that also needs to be addressed. And there's also the physician's lack of knowledge, the discrimination of Alzheimer's disease, and the experiences in actually accurately diagnosing Alzheimer's disease. Those fall on the healthcare professionals' side. Then on both sides, you have the lack of awareness of how great Alzheimer's disease is in our world, the lack of Alzheimer's knowledge, so from the early stages to the late stages, you know, and the various behavioral changes and the challenges that people face. There's also suicide risks when it comes to people with Alzheimer's disease, or actually any of the dementias. Suicide risk tends to be pretty high. There's a low public awareness when it comes to Alzheimer's disease, diagnostic uncertainty on both sides, and diagnostic uncertainty usually refers to the person with Alzheimer's disease. Did they get diagnosed correctly? Because they're feeling some other changes and they're not 100% secure within their doctor's abilities. And then there's the diagnostic uncertainty from the medical field, where the primary care physician may say, oh, you know what, you're just getting old, nothing's changed. that might not be the case. So there's that uncertainty on both sides. Then there's the health and the socioeconomic disparities that we face. And then there's mass media portrayal of what a person with Alzheimer's disease or dementia actually is like. So here we are at the stigma of Alzheimer's disease. So the first thing is Goffman. He is the godfather of stigma. And he defines stigma as a set of negative beliefs disqualifying an individual from full social acceptability within society. When it comes to stigma, it occurs in the individual, interpersonal, familial, society, and institutional situations. The conceptualization of stigma has evolved over time. I mean, it's been, I probably would say probably 50, maybe 59 years, where human differences have been labeled. And they're defined as negative labels to identify a person or a population within a group with either a disability or an illness. Think of stigma. We see it as being a well-documented barrier to help-seeking behavior. It gets in the way of engagement, of care. It gets in the way of adherence to treatments when it comes to basically any of our health conditions. So whether it be Alzheimer's disease or another related dementia, breast cancer, or AIDS, HIV, stigma always seems to get in the way. It is what we call it's just critical, I would say, to understand how the significance of stigma is a fundamental driver when it comes to our population health. Stigma is considered a major disruptor when it comes to multiple life domains, such as resources, our social relationships, our coping skills, and our coping behaviors. It is considered a corrosive impact when it comes to health of populations, when you're experiencing or a person is experiencing cognitive decline, and it also affects their families. It is a significant source of stress and social disadvantage. So stigma, over the years, I've noticed that stigma has a lot of literature on it. It's experienced significant growth. However, it just seems to not be able to go away. It seems to be somewhat, obscured when it comes to moving to the next steps of not discussing stigma of Alzheimer's disease or any other disease. It can also be labeled, it can also lead to being labeled. Individuals get labeled, and when they are labeled, the first thing they're thinking of is anticipating stigma from other people resulting from poor mechanisms by diagnosed individuals, such as keeping their diagnosis private or even limiting their social interactions with others. Why? Because this form of negative coping response is all they can sort of hang on to, but it leads to a harmful social, psychological, financial, and medical consequences. So therefore, when we think of stigma, it's something that we need to resolve to, get rid of it, find a way to deal with it, find a way to work around it. But in order for us to move forward when it comes to certain illnesses, it's something that we do need to deal with. Next page, please. So there are several different types of stigma. I put 5, and the 5 that I put are actually very closely connected to Alzheimer's disease. So these are the types of stigmas that are connected to Alzheimer's disease. So the first one is public and social stigma. So what is public and social stigma? It is a discriminatory and negative attitudes that others have about mental health issues. Now, Alzheimer's disease is not considered under the mental health umbrella. However, the public sees it under mental health issues. There's self-stigma, and that's when there are negative attitudes of mental health conditions that a person has about their own illness. Then there's institutional and structural stigma, when it comes from the organizations, from the services that we actually use. Employment, And this is when there are policies and institutional actions and activities that are actually intentionally or unintentionally restricting the opportunities of the targeted groups of people who have mental disorders, such as an older adult worker who is trying to maintain their employment at their job. If they are working and, for example, they send out a memo and some of the words are jumbled, there's that question of, oh my gosh, am I going to lose my job? What if they find out that I have Alzheimer's disease? Or what if they find out that, I have some form of dementia? What is going to happen to me? Am I going to get fired? Am I going to get, like canned? What is going to happen? So that stigma right there, when they have been diagnosed, they're not likely to disclose that information to HR. They're going to keep that until they can't keep it anymore. There's courtesy, spillover, and association stigma. So usually the word is courtesy stigma, but other people also refer to spillover. It actually means what it says, and association stigma. That usually happens with family members of people who have Alzheimer's disease or other dementia, and they're concerned with the experiences that they're going to have because they're associated with a person who's already being stigmatized. Then there's cultural stigma. Cultural stigma refers to a group of people who are going to have shared beliefs and attitudes that negatively influence the way they actually think about themselves, others, and society when it comes to Alzheimer's disease. So when a disease is as prevalent as Alzheimer's disease, yet it is still poorly understood, it's very easy to for false beliefs to actually spread. When they're left unchallenged, these beliefs perpetuate stigmatizing attitudes against people living with Alzheimer's disease. And as a result, they're reducing their quality of life. These attitudes also extend to family members and other caregivers who are actually living, with the person with dementia, and it also does affect them as well. The unfortunate reality here is that when a person is living with Alzheimer's disease or other related dementia, it is very likely for them to encounter some form of stigma. And I have to say that no one is immune to the risks of dementia, and there are no cures to guarantee prevention of Alzheimer's disease. There's nothing that's 100%. However, you can work towards it. People living with dementia, I can say that this particular disease, they didn't ask for it. So I know that they definitely don't appreciate being labeled or ignored among, the other negative responses that they receive due to their diagnosis. So it's always important to be mindful of how a person with Alzheimer's disease views themselves and views Alzheimer's disease. So what is the impact of the stigma of Alzheimer's disease? Well, first of all, stigma causes suffering. It causes great human suffering. People with Alzheimer's disease often feel dehumanized by being referred to as patients, victims, a case, or even a sufferer of Alzheimer's disease. No one really wants to be referred to as that way. I would say if you're going to refer to someone, I'd say the individual or the person with dementia or the person with Alzheimer's disease. They're actually okay with that. But to group them into a situation where it's a negative perception attached to it, that's something that they're not really happy about. And I definitely understand. The impact of stigma also impacts one's self-esteem, poor mental health, isolation, shame, decreased quality of life, hopelessness, and more isolation. There is a reluctance to ask for help. There's a lack of understanding. They get bullied, they get harassed, and they experience a lot of self-doubt. All of this that I've mentioned also extends to their family members. So what are the challenges of the stigma? So I put only 3 because they sort of encompass everything. As I mentioned, there's a high cost of human suffering, not only on the person who has Alzheimer's disease, but also on their loved ones, whether it be their caregivers or their family members, their adult children. It brings a lot of human suffering. So we need to be mindful of this particular challenge. There's also the obstacles that stand in the way of making the necessary transformation to reduce to reduce the prevention, the cure, the research and diagnosis of Alzheimer's disease. These are things that we want people who experience symptoms to actually want to do. They want to see a cure. They want to find a cure. They want to help us to find a cure. They want to be able to prevent Alzheimer's disease in their next generation. They want to make sure that research is actually done, whether it be social research, clinical research. They want that research to be done, but it also starts with a diagnosis of Alzheimer's disease. Stigma and discrimination are amongst the most negative and most harmful social responses that a person affiliated with or a person who has or has been diagnosed with dementia can experience. So I've put this "did you know" situation because I'm going to read it to you. It's very interesting, but it's very disheartening. So it states that early stages of Alzheimer's disease and other dementia remain underdetected, underdiagnosed, underdisclosed, undertreated, and mismanaged. And it's both on the sides of the individual experiencing the change in their cognition, their loved ones who are being their caregiver, and the healthcare professionals. So often diagnosis occurs at the middle to late stages. And as I said, it's always better to catch it in the early stages where treatments, whether it be drug treatment or a non-drug therapy, can actually help. And it is not sufficiently disclosed. Alzheimer's disease diagnosis is not sufficiently disclosed or even disclosed for that matter. And it's definitely not followed up by the individual with Alzheimer's disease or the physician. And it needs a comprehensive approach. So here we are, we're now at the barriers to early detection and diagnosis. So barriers to assessing for dementia among the general and diverse persons with dementia often include many factors. The first is inappropriate and language incongruent with cognitive test or testing. Few guidelines for using interpreters, both on the person with Alzheimer's disease and the physician, and I'll just say physician, primary care physicians. There's limited know-how-to instructions on providing diagnosis and treatment in an appropriate manner. Usually that also includes a culturally appropriate manner. Not every culture will appreciate certain types of questions. They also look at and deal with Alzheimer's disease or any cognitive issues different from the general population. So we have to also take that into consideration. And an example I will give you is, for example, an individual who is a primary care physician, and he may be, let's say, Caucasian, and he lives right here in Manhattan, downtown New York City. And an individual comes and they say, I'm having some situations with my cognition, or my brain is getting foggy and I'm starting to forget a lot of things, and and they keep going on. And the physician is listening. He or she understands certain things, but then they start to ask certain questions that an individual who is, of a different culture might not understand, because dementia to them may actually mean something very different. They might have totally different beliefs and different traditions about how they actually either take care of that loved one or how they actually deal with it. So that is something that we need to be very mindful of. There's also the awareness of the stigma. Can you go back to the slide, please? Thank you. The awareness of the stigma of Alzheimer's disease. There's a historical experiences from the part of the person with the disease. There's a lack of awareness, a lack of knowledge, the cultural practices, discrimination, traditional beliefs, and of course, mass media and how they portray older adults and Alzheimer's disease. You can go to the next slide. So the importance of early detection and diagnosis. Early detection and diagnosis improves the quality of life, It improves the opportunity for an accurate treatment and, of course, accurate diagnosis. It gives the person the opportunity to participate in clinical trials, to advance research, and also receive medical benefits of an early diagnosis. It affords the families and the affected individual the time to be able to prepare for their future care and for their future wishes, whatever it is that they actually want between that time of diagnosis until the end of their lives. There's there's actually successful outcomes for individuals who are actually diagnosed with Alzheimer's disease at the early stages. So they can get the diagnosis, but they also get proper treatment. What I found is that people who get an early diagnosis of Alzheimer's disease are actually quite thankful. Why? Because they actually know what they're dealing with. They might not know next steps, but they're actually happy that they're relieved that they actually know what is actually ailing them at that time. So it's good for them to actually experience that disclosure of what the disease is. Now, early and accurate diagnosis may reduce the cost of misguided care that is related to occurrences in inappropriate use of medication, over medication, unnecessary medical and surgical interventions, hospitalizations, and emergency visits when there are falls and other incidents. Next slide, please. So providing early detection and diagnosis comes with life-changing diagnosis. Why? Because an early diagnosis is not always welcomed by a person with Alzheimer's disease or their family members. And usually that's because they don't understand what the stages are. They don't understand the changes that they're going to experience. They don't understand the behaviors that may change. They don't understand how society is going to accept them, and if they're going to be able to continue to live an independent life. You'll find a lot of people with Alzheimer's disease actually want to continue to live their independent life as long as possible. But us folks who are in the format of informal caregivers or loved ones want to overhelp, and we sort of dull down their independence. So sometimes we have to learn a little bit about a give and take situation. A person with Alzheimer's disease and their family members typically do not know what the functional or physical changes are when it comes to cognition. And they don't understand that it's gradual, it's over a period of time. Nor do they know how to respond to these changes to minimize their distress, enhance their calmness, to maximize their independence and increase satisfaction with the knowledge of they have Alzheimer's disease and what do they need to do next? What do they need to do next? They need to get instruction as to how to manage, how to live with Alzheimer's disease. So some of the cultural groups, and I'm going to cultural groups because I don't want to leave that out. A lot of them do not see the benefit of actually getting a diagnosis of Alzheimer's disease or getting the diagnosis at all. And the reasons are because dementia, Alzheimer's disease, or any of the other dementias is actually highly stigmatizing within their culture. It can lead to the disconnection in their family and friends. There's a perception that dementia can actually be contagious. There's a fear of marrying into a family who may have defective genes. And there's family fears of financial obligations and the strains of life. So they treat that person as a normal individual where nothing is actually happening. They're just aging normally. Next slide, please. So the impact of delayed Alzheimer's disease and detection and diagnosis involving the individual's quality of life. And I know I've mentioned quality of life. That is so very important. It also affects their ability to age in a healthful manner. Alzheimer's disease, all symptoms, none of them are irreversible. You've got your memory loss, you've got your loss of functioning, you've got your personality changes, and a whole lot more. In terms of irreversible consequences, I always say it's important to make sure you get a diagnosis by a healthcare provider, because whatever symptoms that you may be experiencing may not be or have anything to do with Alzheimer's disease. It might be dementia, because remember what dementia says, memory loss and things like that. However, it could be a urinary tract infection, it could be dehydration, it could be a thyroid problem, it could be alcoholism, it could be a whole bunch of factors that have nothing to do with Alzheimer's disease. So before you jump into it's an irreversible consequence, get checked first. There's also participation of unsafe activities and behaviors, such as driving with Alzheimer's disease. I do know of people who drive with Alzheimer's disease. They're probably in their middle stages. And so for some reason, they're waiting until someone takes those keys away. And also it's for us to also be responsible to take those keys away. There's lost opportunities for treatment and increased caregiver burden when we delay detection and diagnosis of Alzheimer's disease. And due to fear of diagnosis, fear of loss, a majority of older adults with dementia or any of the other dementias actually would prefer to not be diagnosed. They actually die without being told of their condition, without being diagnosed, without even being discussed, with their family or friends. And this is something that it could either be their choice, or it could be the choice of the family member, or it could be the discomfort of a physician. Next slide, please. So continued with impact of delayed diagnosis. When Alzheimer's disease and any of the other dementias are left undiagnosed and untreated, a person with Alzheimer's disease can adversely be affected, especially their quality of life and their ability to age in a healthful manner. Alzheimer's disease diagnosis is typically delayed within 1 to 3 years, but I have seen where it's been delayed for 7 years, where that person is not being taken to the doctor and there's no diagnosis. Delaying the treatments can actually have irreversible consequences, which I mentioned before. And several researchers actually noted that failure to address cognitive impairments related to changes in one's mental health or mental standing actually presents elevated risks for that individual developing further adverse behavioral or psychological health outcomes. So missed and delayed diagnosis often leads to lost opportunities of early treatment, and it increases both the patient and caregiver burden. Next slide. When it comes to physicians and nurses, they play a significant role when it comes to Alzheimer's disease detection, diagnosis, and care, and also for support. A number of physicians can also deter a person from wanting to seek a consultation, because sometimes a person might have to see 3 to 4 to 5 different physicians just to get a full consultation. So that can be a bit of a turnoff. Physicians may not be fully understanding of what the diagnostic criteria for Alzheimer's disease might be. They have minimal Alzheimer's disease knowledge and diagnosis when it comes to dealing with an older adult. They also experience discomfort with the diagnosis and disclosing that diagnosis. Then there are the language barriers. There's a provider factors, as I mentioned before, educational needs, knowledge, and how to, have that conversation with an older adult who might be experiencing changes with cognition. The provider also has various attitudes towards Alzheimer's disease, and those attitudes could be some form of stigma, or it could be discrimination. And also they're concerned about the time constraints. When it comes to a diagnosis in the physician's office, it could take between 10 minutes to about 45 minutes or even an hour. So it all depends on how they plan it out. If you are a person looking for a diagnosis, I say make sure you give the physician a heads up that you want to come in and you want to get a cognitive assessment, especially if you are 65 years and older. You want to get your annual cognitive assessment when you're on Medicare. Next slide, please. So challenges encountered by diagnosis. These are medical challenges. So there's no structured process right now in our federal governments or our local governments. There's no structured processes when it comes to Alzheimer's disease. However, there are structured processes for cancer, HIV, and the other significant diseases out there. Excuse me. There are, oh, am I losing my voice? Excuse me. There are no standardized, excuse me, let me get some water. There are no standardized cognitive tests and guidelines that are established for cognitive assessments. So there are quite a few cognitive tests. There are no guidelines how to use them and what the next steps are after that person has had the test. Then there are cognitive assessments and diagnosis. We've realized that people with symptoms, it's more reactive. That person will more say something like self-report that, you know, my mind might be changing, my brain might be changing, but I'm not sure what it is. And it's for that doctor or physician, I should say, to take that information and give a screening. And we know that though the screening might be difficult, it's important for that individual to be able to live a quality lifestyle. Now, older adults rarely ever have the initiate that conversation that they're having cognitive changes. So there's a variety of reasons for that, whether it's fair cultural perceptions of Alzheimer's disease, stigma, past experiences, not believing in the benefit of knowing that they have Alzheimer's disease. Then they have the question of, why am I bothering to find out? I'm going to be dead soon. So, and Alzheimer's disease is incurable. Some of them do take that attitude, but I say it's better to have a diagnosis to know what you're working with and to be able to live your life accordingly. Next slide, please. Another did you know? So studies have found that stigma interventions have an individual, public, and structural level that can be effective. More research is absolutely needed when it comes to determining the solution to be able to chip away at stigma's effects. The relationships between other social determinants of health require also further exploration, as well as multimodal and multi-level interventions. And improving the equitable distribution, the burden of stigma among populations, including those who are marginalized, is actually essential when it comes to promoting and advancing health equity. The information is needed. It is not just for one group of people, it needs to be for all. And I am sure that the changes would change significantly if it is, promoted accordingly. Next slide, please. So in terms of recommendations, it's important that we address the perceived negative attitudes and perceptions of Alzheimer's disease. So positive change usually starts when you are learning, because you know better, so you do better. When you know the facts behind dementia or any of the, all the other dementia, you're able to make the changes and take those challenging assumptions and the false beliefs that you have and actually share your knowledge, reduce the negative impact of stigma, and also be able to forward that information and the knowledge to your physician, your family, and your caregivers. Stigma just doesn't happen on a personal level. It can happen also at the systematic level. And the response to coping with stigma and discrimination related to Alzheimer's disease it's important that we implement joint and sectoral interventions. So not just on the personal level, but to go all the way up the chain. You can change that slide, but I want to make sure that I include something else here. We need to be able to understand that perceived negative attitudes associated with Alzheimer's disease and other related dementias can prevent a person with Alzheimer's disease or any of the other dementias from obtaining a diagnosis. We also need to understand how our cultural beliefs and misperceptions can actually lead to resistance and the unwillingness to actually receive or give a diagnosis of dementia. We also need to remember that a diagnosis of dementia has considerable impact on identifying an individual with dementia. This effect can also differ among various races, ethnicities, and it also requires considerable adjustment for the person with Alzheimer's disease and their caregiver. And by implementing actions to promote the right to information for Alzheimer's disease, the right to information on the prevention of Alzheimer's disease, the awareness of regarding rights of a person with Alzheimer's disease, such as educational projects for communities in a different social context, for example, in schools, churches, universities, other religious houses, and healthcare services, to be able to disseminate this information regarding rights, Alzheimer's disease, and violations of rights is so very crucial. Now, in closing, I'd like to state that stigma is linked to poor health, delayed detection and diagnosis, greater isolation and loneliness. It increases the risk of poor health outcomes and the stigma of health relationships. Everyone has to make an adjustment for social, isolation rather. Multiple psychological and behavioral processes are often disrupted by Alzheimer's disease, but we have to take into consideration self-stigmatization, the internalization of society's perception of this ghastly disease. There's also the delays in detection, diagnosis, and the resource utilization that may have significant personal and clinical implications for those who are affected by Alzheimer's disease, along with their families. And it includes the challenges in obtaining an accurate diagnosis. I believe that is my last slide. Ladies and gentlemen, thank you so very much. And I believe we're going to be ready for questions and answers.
All right. Thank you so much, Dr. De La Vate Raphael. We don't have too much time left. We were going to finish at 4. So maybe just one question related to this idea of stigma. And I'm wondering, can we learn from the evolution of kind of mental health stigma? Mental health used to be really stigmatized. And in this day and age, we think more about it's okay not to be okay. And that was a long road to get from where we were to where we are now. Can we learn from that? Are there things we can do from that?
Absolutely. As a matter of fact, we can take the exact same course and understand that Alzheimer's disease, though it is not considered a mental health disease, it's a disorder, but it does affect one's brain.
Yeah, great. So we want to be true to our schedule and allow people to move on. It's 4 o'clock. I'm sorry, I'm getting some feedback. But thank you so much for your expertise. If you could see everyone, I know you kind of feel like you're out in the cosmos by yourself in this setup. If you could see everyone, I'm sure they would be applauding and giving you positive feedback. So we really appreciate the attendance of those who came today. Special shout out to my 3rd-year students. I saw a good number of you in the attendees list today. And we just want to thank everyone for coming to our 2nd colloquium sponsored by the Marymount Center for Optimal Aging. So thanks so much, and we'll see you at the next colloquium.
Thank you.
Donna, thank you again. If you'll stay on, once our attendees sign off, we can kind of debrief.